Hello.
Hello and welcome to the new therapy session of the second Academy of Sickle Cell Disease and Thalassemia. We have a great program for you tonight. I'm Miguel Abboud, the professor and chairman of pediatrics at the American University of Beirut. And my co-chair is Biree Andemariam, known to almost everybody in the field of sickle cell, who comes to us from the University of Connecticut in the US. And we have a great session for you today. And I think I will turn it over to Biree to introduce the first speaker.
Thank you, Miguel. Thank you very much. It's a pleasure to be co-chairing this session with you. So today we're going to get started looking at novel therapies that are already approved in parts of the world. And our first speaker is Dr. Julie Kanter. She is the director of the Adult Sickle Cell Program at the University of Alabama at Birmingham. She's a lifespan hematologist specializing in sickle cell disease, focusing on both children and adults. And her research is focused on improving access to care through dissemination and implementation, as well as the development of novel therapies to improve outcomes of those living with sickle cell disease. Dr. Kanter recorded her presentation today and unfortunately is not going to be available for questions, but we can get going with her presentation. And welcome again, everyone. Thank you.
Hi, this is Dr. Julie Kanter. Thank you for inviting me to present today. I'm here to talk about one of the novel therapies, Crizanlizumab, and to present early evaluation of the use of Crizanlizumab in sickle cell disease. This is a National Alliance of Sickle Cell Centers study. The data presented here are on behalf of my co-authors and were initially presented as an abstract at ASH of 2021 with a few extra information thrown in. These are my disclosures. As this audience is well aware, acute pain in sickle cell disease, or VOC, is the most common reason for hospitalization and ER visits. Crizanlizumab is an anti-P-selectin monoclonal antibody, and is FDA approved as a disease-modifying therapy for people with sickle cell disease greater than 16 years of age to reduce the frequency of VOC in the United States. And it's now been approved for over 2 years. To better understand its use and impact, the National Alliance for Sickle Cell Centers conducted a retrospective study of patients who were prescribed Crizanlizumab starting in November of 2019. NASAC is a nonprofit organization formed to support sickle cell centers to deliver quality comprehensive care, adopt specific standards, and advocate for improved health outcomes. At the time of this study, there were 32 recognized sickle cell centers within NASAC, although that number has increased since that time. And this is about a real-world cohort of patients treated at 11 of those centers. Acute painful episodes, as you know, have multi-factors in their cause. VOCs are important as they impact patient outcomes and affect quality of life. And while we used to think painful VOCs were driven only by the red blood cell and its sickling, we know how much the endothelium and the adhesion now plays a role, and that this multicellular adhesion is a major driver of vaso-occlusion in VOC. There are 3 approved therapies at present in the United States to prevent VOC: hydroxyurea, L-glutamine, and Crizanlizumab. Crizanlizumab is an anti-P-selectin antibody, as mentioned, and specifically is aimed at reducing the interactions between the neutrophils and the endothelium, as well as the sickled red cell in the endothelium. When we think about how we identify individuals for specific therapies, specifically at my home institution, the University of Alabama at Birmingham, we look at what we consider a practical phenotype. Are they very hemolytic? Are they having a higher hemoglobin with more viscosity? What type of disease do they have? We also discuss whether they've had a history of stroke or at a high stroke risk, because if they have, we automatically recommend transfusion therapy. We recommend hydroxyurea, hydroxycarbamine, for everybody living with sickle cell disease, regardless of genotype. And after that, we again try to examine their phenotype. If they have SS disease and have low hemoglobin, we consider Voxelotor as an option, which we know is not available in the UK at this time. If they have more frequent VOCs, we're more likely to consider L-glutamine or Crizanlizumab. Similarly, if they have SC disease with frequent VOCs, we may consider Crizanlizumab, but we may also consider chronic transfusion therapy or a combination of phlebotomy and hydroxyurea. As mentioned previously, those at high risk of stroke are automatically initiated on transfusion therapy. The SUSTAIN study was a randomized, double-blind, placebo-controlled, multinational phase 2 study looking to evaluate the efficacy and safety of Crizanlizumab in adults greater than 16 years of age who had experienced between 2 and 10 VOCs in the previous year, and has been previously reported on several different occasions. Importantly, key findings from SUSTAIN showed that the median rate of VOCs was reduced by 45% with the approved dose of 5 mg per kilo across all patient groups, whether or not they had received hydroxyurea, regardless of genotype, and regardless of how many VOCs they had had in the year preceding the trial. Importantly, however, only 67 individuals actually received the approved dose prior to the approval of this medication in the United States. Thus, it is very important to better understand the real-world use of Crizanlizumab. So we wanted to evaluate Crizanlizumab practice and summarize data for the United States on insurance approval and how frequent the drug was discontinued, and also understanding why patients chose or providers chose to discontinue it. In the second part of the study, we did a highly in-depth assessment of patient-level data to really characterize sickle cell disease history, previous treatments, to evaluate frequency and reasons for discontinuation, evaluate side effects or infusion reactions associated with Crizanlizumab, and to evaluate acute care use, which for this purpose of this study was defined as hospitalizations and ER visits for the first 12 months prior to starting Crizanlizumab, and including the 12 months after the first dose of therapy. As I mentioned, the methods for Part 1 were population-level data on the approval and use of Crizanlizumab at the different sites. Part 2 honed in on patient-level data. For this, we looked at patient doses and total number of patients and how many doses each individual received. We looked at effectiveness based on number of doses, pretreatment VOC, and concomitant hydroxyurea use and genotype. Note that hydroxyurea use and pre-VOC treatment burden evaluations are still pending. We used chi-square tests as appropriate, as well as sample t-tests. Here I'm showing you the results of our population-level information about each participating center. As I mentioned, 11 centers participated in Part 1, which accounted for approximately 6,320 individuals living with sickle cell disease. About 5% of those individuals were prescribed Crizanlizumab, almost 300 individuals. Initially, we had 35 patients in this cohort who had been denied by insurance, which represented 11.8%. However, most of those were able to be appealed and were successfully able to be prescribed to individuals. Overall, when we looked at our Part 1 data, it took several different time periods to be able to use this drug once we had site level of formulary approval at our hospitals. Mean time from site level approval to first infusion was actually 77 days. And so the first patient to receive treatment at each site varied considerably between January of 2020 to January of 2021. And as I mentioned previously, although some patients did receive denials, most patients were able to have prior authorizations placed and sites were able to overcome those denials. We have patient-level data from 10 of the 11 centers. This included 297 patients that had been prescribed Crizanlizumab, and of that group, 241 had received at least one dose. When we look at the demographics, you can see on the right the demographics of individuals who had received at least one dose of Crizanlizumab. The majority were SS disease, though many also had other genotypes. Now honing in on the group that had received at least one dose of medication. This was 241 patients. Notably, about 80% had received or were currently receiving other sickle cell disease modifying therapies, and that information is presented below. We can also look at this group of individuals by previous comorbidities or concurrent comorbidities. And it's important to note that many of these individuals had significant other complications of their sickle cell disease. Specifically want to call out that many of these individuals had chronic pain or were on long-acting pain medication when they were started on Crizanlizumab. We also wanted to understand why patients might have stopped Crizanlizumab. So here we looked at the number of patients that have continued, about 70% of the cohort, and those that had discontinued. Specifically, as I mentioned previously, 241 patients had already received at least one dose. and the median number of doses received was 7.65, but it ranged from 1 to 20 per patient. Of this cohort, about 2/3 are still receiving Crizanlizumab. I want to specifically look at those doses and how many they had received on the right prior to stopping this medication. And as you can see, those who discontinued had a median stop of 3.5 doses. So they had not potentially received a sufficient dose in order to demonstrate efficacy. So let's look closer at this individual group of patients. As I mentioned, 78 had discontinued Crizanlizumab, and we wanted to better understand why they had stopped. The majority, about 30%, as you can see on the left, discontinued because they just didn't feel it was working. However, as many of these individuals had only received 3 to 4 doses, it is unclear whether that was sufficient for them to experience efficacy. We saw some who felt they had an increased incidence of pain crises. In some cases, provider discontinued the medication because they didn't feel it was working for the patient or because the patient had missed many appointments. And we had only 7 patients who discontinued secondary to infusion-related pain reactions. Now we're going to look more closely at those individuals who had received at least 12 doses at the time of this analysis. As I've mentioned, data collection is ongoing and more information will be available. At the time of this analysis, 58 patients had received more than 12 doses or at least 12 doses of Crizanlizumab. And of that group, 55% had a notable decrease in ER and inpatient visits. 12% had the same as they had in the year previous, and 33% had an increased number. We're going to look a little bit more closely at those 32 patients, or 55% of this cohort had a decrease. We wanted to understand how much of a decrease they had. And as you can see here, looking at those 32 patients, they actually had a decrease in their average length of stay, their number of hospital stays from prior and current, and their number of emergency department visits, and all of this was significant. There have been reports of infusion-related reactions to Crizanlizumab, both externally, as presented in my previous abstract, as well as in this cohort. And we want to better understand and see if we can predict who could be affected by these IRRs. So in our group, we found that 14% of patients described some amount of IRR or some infusion-related reaction. This included any symptoms of any type that a patient might have mentioned during the infusion. This included nausea, itching, as well as the more common or more discussed type of IRR that are these acute pain-related IRRs. On the right, you can see that 19 patients experienced an acute pain IRR, or 8% of those who had received any doses of the medication. Of this group, 8 discontinued after having had an IRR, though 11 patients continued to receive Crizanlizumab despite having had an acute painful IRR. 3 of those did not have any further ones, and 8 had additional pain-related IRRs, but found they were manageable and were able to continue receiving Crizanlizumab. This is the first multi-center study that shows a real-world analysis of Crizanlizumab, and is our first National Alliance of Sickle Cell Centers reported study. It provides an in-depth characterization of the medication, followed by the same patients before and after treatment for at least 12 months, for a total of 24 months. This is also important, as I mentioned previously, because 67 patients had received the total of 5 mg per kg at the time of the approval of the medication. Here we discussed 241 individuals who had received at least 1 dose of the medication, and 58 who had received it for at least 12 doses. As I've also mentioned, ongoing data collection is in progress. Overall, we noted that Crizanlizumab was relatively available to patients at NASAC-recognized centers, and that while there were some barriers to therapy, most were able to be overcome and were not regionally dependent. Over 2/3 of patients who had started the therapy had continued on therapy, and very few patients had an acute painful infusion reaction, and even less than that discontinued as a result of an acute painful IRR. Over half of the individuals who'd received at least 12 infusions had a significant reduction in hospitalization and emergency department use. We understand that improving phenotype-specific response to novel therapies will be key in understanding what is optimal in sickle cell disease, and it will require longitudinal clinical registries. Furthermore, we understand that these real-world evaluations of use of medication are very important to understanding both the disease process as well as individualized patient responses to disease, and hopefully we will have a future that involves precision medicine in which we can identify which individuals will respond best to which therapies. Thank you very much, and I appreciate again being invited to present today, and I'm so sorry that I could not be with you in person.
Thank you, Dr. Kanter, for that great presentation on real-life data on Crizanlizumab. Now, to present data on the other approved therapy, Voxelotor, is my co-chair and dear friend, Dr. Biree Andemariam. And Biree is a professor of medicine at the University of Connecticut School of Medicine. Biree is a well-known investigator in sickle cell disease. She is the lead principal investigator on 3 early and late phase new therapeutic trials. And she has played a very important role in the sickle cell community, both by starting the New England Sickle Cell Institute, where she's a physician scientist, and she is the immediate past chief medical officer of the Sickle Cell Disease Association of America. And I could go on and on, but I think that's should be enough. Julie is very much with us today, and she will be available for questions at the end. So Julie, Biree, we look forward to, Julie will also be available with us at the end, but Biree, we look forward to your talk on Voxelotor.
Thank you very much, Miguel. Yes, I appreciate that introduction greatly. So I'll have my first slide, please. So thank you to the organizers, particularly Dr. Anusa, for inviting me to describe some real life experience of the use of the novel therapeutic Voxelotor, which we've been fortunate enough here in the United States to have as part of our treatment regimen available to patients for over 2 years. And today I want to introduce some real world studies, the retro study and the prospect study that are both underway to systematically look at the real world experience of the use of Voxelotor. Next slide, please. These are my disclosures. Next slide, please. So as many of you might know, Voxelotor is an oral, once daily hemoglobin S polymerization inhibitor. And it was approved for use in sickle cell disease in individuals 12 years and older back in 2019 in the United States. And then more recently has been approved for use in children as young as the age of 4 years. As most of you probably know, sickle cell disease is an inherited systemic disorder where the sickle hemoglobin, hemoglobin S polymerization within the cell triggers red cell sickling, chronic hemolytic anemia, as well as the devastating, recurrent, unpredictable episodes of vaso-occlusive pain that many individuals living with sickle cell disease call either a pain episode or a sickle cell crisis. Sickle cell disease-related complications lead to both acute as well as chronic and sometimes life-threatening events. The disease also leads to cumulative organ damage that we see in particular as individuals age with sickle cell disease. It also contributes to disability and early mortality. Voxelotor has been shown in clinical trials to increase hemoglobin levels as well as to reduce markers of hemolysis. It is a first-in-class hemoglobin S polymerization inhibitor, and its approval was based on randomized, placebo-controlled, multi-center trials, the HOPE study, and then the HOPE Kids trial. Next slide, please. Registry studies, I really believe, can provide really excellent real-world evidence of how novel therapy can benefit a population. And this is being studied in Voxelotor in 2 ways. One, the retro study, which I'm going to focus on today, and the prospect study, which I'm going to introduce. The retro study is a retrospective study to look at outcomes in patients who were treated with Voxelotor, whereas prospect is designed as a longitudinal prospective registry to look at the long-term safety and effectiveness of Voxelotor in individuals with sickle cell disease. Both designs of these studies are looking at similar things. Well, clinical outcomes, the utilization of healthcare resources, so hospitalizations, doctor's visits, emergency department, or as many of you call it, A&E visits, health-related quality of life, which is important, especially to those living with sickle cell disease, as well as looking at long-term safety and tolerability. Next slide, please. So the Retro and Prospect Steering Committee, which I chair, has several members whose names are outlined here. Next slide, please. Now, I want to focus the bulk of this talk on the retro study, and much of what I'm going to present today is a bit of an encore from an abstract that was presented at ASH last month, the American Society of Hematology meeting. And on behalf of my co-authors, I'll be describing what we had in that abstract, which was the latest data from the retro study. So retro is a post-marketing study that is designed to collect, characterize, and aggregate real-world, retrospective, clinical, as well as laboratory data on adults and adolescents age 12 and older with sickle cell disease who are treated with Voxelotor as part of their usual standard of care. The study is ongoing and will include approximately 200 individuals with sickle cell disease from 10 study sites across the United States. Data will be and is currently being extracted from medical records, and the data are being examined 1 year before and up to 1 year after the initiation of Voxelotor as part of the usual care in these patients. The data are documented in de-identified case report forms and captured in an electronic data capture system. And again, the steering committee provided very critical independent sickle cell expertise to inform the design of both the retro study as well as the prospect study. So in looking at key eligibility criteria, all genotypes for sickle cell disease are included. Individuals could be entered into the retro study if they had been treated with Voxelotor for at least 2 consecutive weeks, and they were not currently or in the past participating within the previous year in an investigation or clinical trial or any expanded access program for Voxelotor. So on the bottom right there, you'll see the schema for the retro study design. So we're looking again at 12 months prior to Voxelotor initiation, and then looking for up to 12 months post, 3, 6, 9, and 12 months of data on Voxelotor. Next slide, please. So looking at the demographics, as of the data cutoff that we had in October of 2021, we had already gotten 140 patients into the retro database. And if you look at the demographics and baseline characteristics here, you'll see that the mean age is about 32. We have individuals as young as 12 and as old as 71 years in the retro data set. The majority of patients, 45%, are between 18 and 35 years of age, but we have decent representation, almost 16% from the under 18 year group. And looking at sex distribution, fairly even between males and females. The racial distribution is what is usually the usual pattern seen in the United States, with about 88% of patients identifying as Black or African American. And in looking at genotype, 87% of the 140 patients have the hemoglobin SS genotype, 6% hemoglobin S beta 0, just a few SC, and just about 1% S beta plus. When looking at baseline hemoglobins, interesting distribution here. About a quarter of patients on Voxelotor in this database had a baseline hemoglobin less than 7. 60%, the bulk of patients, had a hemoglobin at baseline between 7 and 10.5 grams per deciliter. And actually 5% of patients had a hemoglobin over 10.5 grams per deciliter at baseline. When looking at current hydroxyurea use or concomitant hydroxyurea use in this database, about 2/3 of patients were also on hydroxyurea. Next slide, please. So looking at Voxelotor administration, in terms of the duration of therapy, the mean number of weeks was 53, so about a year. Some patients, the maximum, had been on Voxelotor for over 2 years, 124 weeks. The distribution of duration of therapy is then listed there. You'll see that nearly 60% of patients in this data set had been on Voxelotor for more than 12 months. Looking at the initial prescribed dose, this is very interesting. So the daily recommended dose for Voxelotor is 1,500 milligrams daily, which is 3 500 milligram tablets. And you'll see here that the initial prescribed dose was 1,500 milligrams in 87% of patients, but in 13% of patients, the initial prescribed dose was somewhat less, either 1,000 milligrams or 500 milligrams. The reasons for prescribing Voxelotor, I think this is very interesting. So again, Voxelotor was approved on the basis of its ability to reduce hemolysis and increase the hemoglobin level. So it makes sense that, as you see here, 64% of patients were prescribed to reduce anemia and 8.6% to reduce the need for a blood transfusion that goes along with its known mechanism of action. But I think what's really revealing here is that 31% of patients were prescribed Voxelotor to reduce pain, and nearly a quarter were prescribed to reduce the frequency of vaso-occlusive crises. So that's very, very interesting that the reason for prescribing Voxelotor in the first place, based on what the physicians were documenting in the medical chart, were a little bit different from what the indication was based on the approval. So looking at dose changes on the right-hand side there, there were dose changes and dose interruptions in 22% of patients. There were dose adjustments in 18% of patients. And looking at the reason for dose changes, so 16% were due to some adverse event, but nearly none due to a perceived lack of efficacy or a perceived pill burden on the part of patients. Next slide, please. So looking at some of the laboratory data in the retro data set, looking specifically at mean change in hemoglobin response through month 12. If you look at compared to baseline, there was about a 1.5 gram per deciliter mean increase in peak hemoglobin increase at any time in this cohort of patients. And if you look at 3, 6, 9, and 12 months post initiation of Voxelotor, there were increases over baseline. Next slide, please. Looking at this waterfall plot, which looks at 99 patients and their peak hemoglobin change from baseline at any time during the study period, you'll see that there's quite a wide distribution of peak change from the patient's baseline. If you look on the left, there are some patients who had 4, 5, 6 gram increases in their hemoglobin. And you'll also notice in this waterfall plot that the overwhelming majority did have a response, an increase in their hemoglobin, and certainly the majority of patients with an increase of over 1 gram per deciliter, and very few non-responders on the right-hand side of the waterfall plot. Next slide, please. In looking at markers of hemolysis, the mean change in reticulocyte percentage following Voxelotor treatment did decrease at both 3, 6, 9, and 12 months, which is consistent with the mechanism of action of reducing hemolysis. Next slide, please. And this was further seen with another measure of hemolysis, that being the indirect bilirubin. And again, compared to baseline, there were decreases in the indirect bilirubin that were sustained over time. Next slide, please. What about safety and tolerability in the real world? Well, there were 30% of patients had any adverse event at any time during the retrospective review. But looking specifically at adverse events with at least a 5% incidence, diarrhea, headache, and rash were the 3 that emerged. But importantly, those were exactly the side effects that were seen in the clinical trial, the HOPE study. So no new safety signals in the real world here, which is good. And looking at dose discontinuations and modifications due to adverse events, About 6% of the patients discontinued due to an adverse event. 12% had some dose interruption, and about 16% had a dose reduction. In my own experience, a lot of those dose reductions are in the setting of patients who have diarrhea or GI upset, and oftentimes reducing the dose minimally can get rid of that side effect. Next slide, please. So in conclusion, specifically to the retro study, I hope you'll see that this is really the first multi-center retrospective examination of the real-world effectiveness of Voxelotor, and that we're beginning to describe in the first look at this data as it evolves, some of the changes in the laboratory outcomes in individuals with sickle cell disease. The study so far shows that treatment with Voxelotor is associated with an increase in hemoglobin and reduction in hemolytic markers, which is similar to the HOPE study, and that the safety data are also consistent with that of the HOPE trial, and no new safety signals in the real world. So we're going to be continuing to complete the data pool for all 200 patients expected to be in the retro data set. And eventually we'll be in a position, once we have all of the data, to include evaluation of very important non-laboratory and clinical outcomes, including transfusion needs, health resource utilization, as well as the ability to stratify these outcomes based on age, baseline hemoglobin levels, genotype, and concomitant hydroxyurea use. So this is going to be a rich data set that's going to allow us to answer a lot of questions. Next slide, please. I wanted to just take a moment to introduce the PROSPECT studies. This is a much larger registry study. It's going to be a prospective chart review. It's just started to enroll. There will be about 750 individuals with sickle cell disease, at least age 12 or older, enrolled into the PROSPECT study at about 45 sites across the United States. And these will be patients who are prescribed Voxelotor as part of standard of care. So briefly, after initiation of Voxelotor, we will look at 12 months of data prior to initiation of treatment, and then look for 5 years prospectively at how these patients do on Voxelotor. This will include continuing to follow these patients even if they discontinue Voxelotor or if they have a pause in treatment. The clinical data are going to be collected directly from patient medical records following informed consent, and we will be able to also get quality of life data collected directly from patients, which is something that was really not able to be done with a retrospective study design. And pending SNDA approval, we plan to expand the PROSPECT study to include patients between ages 4 and 11 years as well. Next slide, please. So thank you very much for allowing me to introduce these real-world registries and retrospective reviews that I think are going to answer some really critical questions about Voxelotor.
Biree, that's great. Are we going to take questions for you right now?
Sure.
And let me see if there are questions in the chat. No questions yet, but I have a question for you. How do you explain, or that the benefit that the patients on Voxelotor see, and they certainly feel better with the data that's coming out, that there is a trend but not an improvement in the number or frequency of painful vaso-occlusive episodes?
Yeah, so I think that's important, and that question will be able to be addressed and answered and examined in the retro study for sure, but probably with more rigor with the PROSPECT study design. I think we're going to get a glimpse as the retro data set is completed and the full data analysis takes place, probably within this first quarter of this year. We'll be able to look at the change in vaso-occlusive crisis episodes pre and post Voxelotor initiation. So that's super important. And what I do want to say is, of course, this is anecdotal, but having prescribed Voxelotor in adults for over 2 years now, probably to maybe 40 patients, maybe 50 patients, there are anecdotal remarks that I get from patients fairly consistently and without prompting. And these were endpoints that were not part of the clinical trial design. And for example, I have patients who will tell me, now that I've been taking this drug, maybe my pain crises aren't changed as much in frequency, but the strength of the pain crisis, the severity of the pain crisis, how high my pain score gets seems to be different, seems to be better. So I think that there are subtle differences in the pain crisis experience that we have not done a good job, I think, in trial design of trying to answer. But these are important to patients. So, when you talk to patients and they say, I have, my pain crisis, I'm a 10 out of 10, that's when I go to the hospital. Same patient might say, well, it's not the frequency of the episodes so much, it's whether or not that episode disrupts my quality of life. So if I still have the same frequency of episodes, but they're not as severe, that can be an improvement. That can be a quality of life improvement for patients. So I think those are the types of questions we need to start to address.
And thank you. And this you just segued well into the question that's come in from the audience. Thank you for great presentation. In a patient who has a laboratory response but doesn't appear to have a clinical response, example, same or increased fatigue despite increased hemoglobin. How do you approach this with the patient who may not want to continue treatment due to no perceived benefit? And then there's a second question, which I think, Dr. Kanter addressed in one of the slides. How do you decide between different treatments? What about the future? Do you see these as bridging therapies to transplantation? Now, I take a little issue with that statement, but I'd like to see your answer.
Okay, well, the first one, so, how do I deal with patients who might have a laboratory response, but don't necessarily feel any different? So I think one thing that we need to start to talk about when we talk about novel agents, particularly those who have clinical trial endpoints focused on raising hemoglobin, is to kind of flip that around a bit. And how are we raising hemoglobin with these drugs? Well, we're reducing hemolysis. And I think we all have some idea that there is significant pathophysiology associated with increased levels of hemolysis in our patients. And I think that over time, there are going to be clinical endpoints that are currently being examined with Voxelotor. For example, looking at chronic organ damage, looking at progression from early stage kidney disease to later stage kidney disease. Okay, that's not something a patient is going to feel, correct? But if we can demonstrate that daily use of a drug like Voxelotor prevents progression of renal disease, that's significant. Again, not something a patient is going to feel. There are also trials looking at progression of abnormal TCDs in children with sickle cell disease who are on daily Voxelotor. So there's a clinical trial right now taking kids with conditional TCDs, giving them Voxelotor daily and seeing if there's any improvement in that TCD velocity. Again, not something anybody's going to feel, but these are potential markers of progressive disease, organ damage that are important to address. So those are the types of things I would talk to my patients about. But again, it's an individual decision. If the patient doesn't feel that taking a daily medication is making them feel better, we talk about it. Sometimes they'll stop, but in both the retro data set as well as my own anecdotal experience tells me that most patients want to continue therapy.
Mm-hmm. And about them being a bridge to transplant, I don't know how you feel about that.
Do you mean that patients would have to fail all approved therapies before getting transplant, or?
Yeah, I mean, and if I may throw in my 2 cents, I would disagree with that. And I feel if somebody is a candidate for transplantation, they should go for transplantation as soon as possible. Now, you might want to try one of these drugs And if it works, they might change their minds. But I wouldn't say, well, let's try this until, you have the money to have your transplant or something.
Right. I would agree with you.
Now, a couple of other questions is, should we have stopping rules? Let's say if people don't respond to these expensive medications by 6 months or 12 months, then we discontinue them. And then there is a question about kids, and they have seen tremendous responses, of hemoglobins going up, a rise of 5 or 6 points. Now, would you have to discontinue if the hemoglobin went up too high? So would you discontinue after 6 months if no benefit? And would you stop if the hemoglobin went up, let's say above a certain value?
So I think the question about stopping and having, sort of a priori defined, 6 months versus 12 months trials on a novel therapy. I think if there was no improvement in hemolysis or hemoglobin, you could make an argument after 6 or 12 months that perhaps this wouldn't be the best choice to continue. I think what you'd have to address with that particular patient is compliance, because, the HOPE study did show us that there's a swift increase in hemoglobin just after 2 weeks of therapy with Voxelotor, and that increase is sustained. But if you can establish with your patient that they are compliant, they're taking it as prescribed, they're taking the full dose, and they're still not having a laboratory benefit, then that's a discussion that you can have with the patient about whether or not they should continue. I think that's fair. I certainly do that with Crizanlizumab. So I say to patients, and this is getting to Dr. Kanter's talk, but if patients are considering Crizanlizumab, I say, let's give it at least 6 to 12 months to see whether or not you have a decrease in your vaso-occlusive crisis frequency. I think it's too hard to, get a novel agent and just take it for a handful of months and make a decision at that time. What was the last question, Miguel?
Is there a threshold level above which you would not want the hemoglobin to rise and you would discontinue the drug if it was too high?
No, not really. I mean, certainly if they're above normal, I think. But I think in my own population, I've had patients who've had robust responses, 3, 4, 5 grams per deciliter, absolute increases in hemoglobin. I don't have any angst about that. And I think that's because the data on Voxelotor have been sliced and diced many ways, many times in multiple abstract presentations at ASH and EHA and ASCAT. And I have not seen any data to date, and I've been looking, I've not seen any data to date that suggest that higher absolute increases in hemoglobin confer a more deleterious side effect profile. I've not seen that. I think that that's one of the important reasons to do a study like RETRO and the prospect study, to see for sure, especially prospectively, if we're getting any of those safety signals. But to date, I'm not aware of any of those safety signals. In fact, my patients just anecdotally who get a 2, 3, 4 gram rise of hemoglobin feel well. They feel well, they're sleeping better, they're less fatigued.
Yeah, and the one question that was there is, which drug would you choose for which patient, for those of you who are lucky to have both drugs available?
Yeah, I don't want to steal the thunder of the panel that's coming up a little later, because I think they're going to be focusing on that question.
All right, good. And then we can chime in then as well. So okay. If not, thank you, Biree, very much for a great talk and for taking the questions. And as the co-chair, you introduce the next speaker.
All right, thank you. Thank you, Miguel. Well, I have the pleasure of introducing my friend and colleague, Dr. Bart Biemond, who's an internist and hematologist at the Academic Medical Center of Amsterdam at the University of Amsterdam in the Netherlands. Dr. Biemond is working in the Academic Medical Center as a senior staff member of the Department of Hematology and is responsible for general hematological care, both benign and malignant hematology. His focus of research and clinical expertise is sickle cell disease and thalassemia. He's the head of the Sickle Cell Thalassemia Expert Center for Adult Patients. He's focused on clinical and preclinical studies on vasculopathy and sickle cell disease, Furthermore, he's a member of the Dutch Hemoglobinopathy Working Group, consisting of hematologists, pediatricians, laboratory specialists, and specialized nurses, and is medical advisor of the Dutch Patient Foundation for Sickle Cell Disease and Thalassemia. Welcome, Dr. Biemond. We look forward to your talk. And I know you're giving it live, so we'll definitely be able to get some questions and answers at the end. Thank you.
Thank you. Thank you for this very nice introduction. I will wait for my slides to appear. Yes, there it is. Well, I would like to thank the organizing committee and especially Baba to invite me to give a lecture on emerging therapies, which was actually not very easy because if you compare this with a few years ago, the amount of different drugs that may be helpful in patients with sickle cell disease is really increasing rapidly. And before I go on with this presentation, I will show you my disclosures. None of the subjects I will address will have a point with this. Well, despite this enormous flux of new therapeutic agents, I would like to stress that we still walk in a desert when you look at the therapeutic options in the sickle cell disease. Of course, Crizanlizumab, Voxelotor, and L-glutamine have been approved in the United States, but in the rest of the world, this is still a drug that we cannot use in the clinic. So the little oasis you see in this cartoon, that is actually consisting of hydroxyurea and transfusion in most parts of the world. And that is still, well, that is dreadful. And we're looking forward to new therapies that we can really use in clinical practice. If you look at sickle cell disease pathophysiology, it is quite complex. And there are a number of key processes and targets. And the key processes in sickle cell disease are, of course, polymerization. That's where it all starts. Chronic hemolysis, inflammation, endothelial damage, cellular adhesion, giving rise to vaso-occlusion, and finally the ischemic and reperfusion injury, and organ damage, morbidity, and finally mortality, which is the main focus of the disease. But if you look at all different targets that involve these different aspects of the disease, it's becoming very complex. And if you try to investigate what the relation between those different factors is, it's becoming even more complicated, as you can see by the number of arrows that appear there. And well, if you see a diagram like this, it means mostly that nobody understands how the disease is really working. One other way to show how sickle cell disease is working is presented by Joshua Field a couple of years ago at the ASH meeting, and I still like this figure very much because it gives rise to the impression that it is a disease that is continuously going on. So vaso-occlusion is not something that happens if a patient arrives at the ER with pain, but this is going on and on. And there are a few targets involved. So that is indeed cellular adhesion, polymerization, vaso-occlusion, hemolysis, oxidative stress, and inflammation. And I guess that a drug which is really targeting most of these different aspects of the disease will be the drug of choice. So going on to emerging therapies, I only selected 3 therapies for this talk. And it will not be a surprise that one of them is pyruvate kinase activation. We have seen during this conference already a number of presentations showing the activity of this compound in sickle cell disease and thalassemia. And I would like to show some of those details and try to stress out whether this is a drug we can expect to be effective in the sickle cell disease. First of all, pathophysiology, PK activity is reduced in sickle cell disease and is involved in the increased 2-3 DBG levels in red blood cells, a decreased ATP level in red blood cells, which is related to the rapid deoxygenation of the hemoglobin, which can rise to the sickling process in the vaso-occlusion. By activating purified kinase by drugs, you can actually restore this. So the T3 GPG goes down, which increases the oxygen affinity of the hemoglobin. ATP levels in red blood cells go up, stabilizing these red blood cells. And as we have seen in the previous presentations during this meeting, this has a serious impact on the rate of hemolysis. And I will show that in the next slide. One of those agents, etavopivat, is a oral available drug. We saw some data just earlier this afternoon by Dr. Thielen. Generally, it gives a rise of the hemoglobin level of 1.1, 1.2 gram per deciliter, and almost of more than 80% of the patients have an increase in their hemoglobin level of more than 1 gram per deciliter. Well, there were a few side effects. I think that the side effects are difficult to address from a phase 1 study because there is no control group. So you should be careful with those. But interesting is that not only the hemoglobin level goes up, this slide you can see that the point of sickling using the oxygen scan is also improving, which is not a surprise given the higher oxygen affinity, but also the PS expression on red blood cells, which is related to the thrombophilia, and also the activation status and adhesion of red blood cells is increased. And also the oxidative stress is reduced by applying this drug to patients with sickle cell disease. And last but not least, also the inflammatory response given in this very small study presented at ASH as well in TNF levels, and also the prothrombin factor 1 and 2, which is also decreased, shows that the reduced hemolysis not only brings up the hemoglobin level, but also brings down coagulation, brings down the inflammation, and has an effect even on EPO, although that is not statistically significant in this group, but we saw that in the thalassemia group, that the EPO levels really go down. The other drug, which is doing exactly the same thing, is mitapivat, which is also an oral drug, has also presented here during this meeting, but also at ASH, showing a similar response on hemoglobin, 1.2 gram per deciliter, and an increase of more than 1 gram was found in more than 50% of the patients that were treated with mitapivat. Also in mitapivat, there was an effect on the point of sickling, and there was an effect mainly on hemolysis. So if you take all these studies that have been presented at ASH and have been presented during this meeting together, you can say that this drug, the purified kinase activators, reduce the polymerization by decreasing the 2,3 GPG. They stabilize red blood cells by the increase of ATP and reduce hemolysis, which then causes a improved anemia, reduced coagulation activation, reduced inflammation, and a reduced oxidative stress. Both drugs are currently in clinical trials, so we will wait for those results to see whether it is indeed as promising as presented here at ASH earlier. A drug which is not mentioned so far during this meeting, I have selected this one because it is really an interesting compound, an interesting target for sickle cell disease, and I would like to show you this. Although there are no data so far in patients or in humans, so this is really preliminary, but very interesting, I guess. NRF2 is a translation factor which is important in the antioxidative stress response in blood cells. And these data are presented to you now were presented in Blood Advances last year, and showing a mouse, a sickle cell mouse, a Townes mouse, which was overexpressing NRF2. And what you can see in this slide is that it gives a reduction in the pulmonary inflammation. It gives a reduction in liver necrosis in this specific model, a reduction in PCAM and P-selectin, and it does give a reduction in vascular leakage in the lung. So it seems to have a major effect in this mouse model on the presentation of sickle cell disease in this specific model. At ASH, also a study was presented in which a oral NRF2 inducing agent was presented. It's called IMR261. And here you can see how it works. So NRF2 is silenced by KEAP1. As long as it is binded by KEAP1, it doesn't work, and it is degraded, so it doesn't have its effect. And this oral agent, the NR261, that releases NRF2 from this KEAP1, and that active part translocates to the nucleus, and then this gene expression of, well, not only the antioxidant stress genes, but also the fetal hemoglobin production goes on, and the NF-kappa B is inhibited. And I will show you the results in two different experimental setups. This is in a human CD34 bone marrow progenitor cells. And if you expose this drug to those cells, you see a very dose-dependent increase in the HbF levels. In a mouse model, the well-known Towns mice model, there you find exactly the same effect with a rise in the hemoglobin levels. Interesting, if you give these mice a TNF injection to induce a vaso-occlusive crisis, it also inhibits B-selectin expression, L-selectin expression, free heme, and bilirubin levels. And taking this all together, NRF induction generates an antioxidant stress response. It induces HbF induction. It reduces hemolysis. It reduces inflammation, reduces endothelial activation, and improves anemia. There are currently no trials, no clinical data. It has been applied to humans, but mostly for other diseases. So I'm really looking forward that this drug is further studied in patients. But I find it a very interesting target and a new target which has not been very well known so far. Well, the third emerging therapy might surprise you, because allogenic stem cell transplantation is there for many, many years. But the reason I choose this as an emerging therapy is that it is now safely applicable to adult patients, and I will show you the history of that. So the allogenic methylated stem cell transplantation in sickle cell disease is of course applied to children for a long period, but not in adults. And this was first introduced by the group of the NIH, who showed that by a very non-toxic conditioning regime consisting of no chemotherapy, without any effect on fertility, and with minimal admission duration of less than 10 days in hospital, patients could be treated and could be cured of their disease. And last year, a overview was given by the three main centers, two centers in the US, one in Washington, Chicago, and a center in Saudi Arabia, Riyadh. They presented their data on 120 transplantations they performed, and 65% of these patients were above 30 years of age. And I don't go much in detail, but here you see the results. So of those patients, the overall survival in patients with a mean age of around 30 was 93%. So only a mortality rate of 7% in this study, and a disease-free survival, so without sickle cell disease, in 85% of these patients. And also, graft versus host was only seen in 2 patients of the 122 that were included, and graft failure was actually the biggest problem. So in 30% of the patients, there was a graft failure, and patients get back to their initial disease. Of course, in the patients that were successfully transplanted, there was a normalization of the lab, and there was no more progression of organ damage, which was demonstrated in this specific study as well. These are also important slides. So what happened over the years? So here you see that for 5 years they looked at the chimerism for the myeloid and for the T cell chimerism, and the T cell chimerism came up to 80%. So 80% of the T cells were from the donor, the other T cells were from the patient itself, and this was very stable for a long period of time. There was also viral reactivation in these patients, which was mostly mild. It was a 10% reactivation of CM fever for what the treatment was needed, and a couple of and a few patients that needed treatment for EBV or varicella zoster infections or reactivations. What I would like to add on that is that that there is a new study that has been performed actually in our center. It's presented today by Lisa Duffern, and she showed that the graft failure of 13% we might be able to attack that by a preconditioning regime. And this study showed that if you add azathioprine and hydroxyurea, this both targeting the very busy bone marrow and the immune system, by using that you can try to improve the results of these transplantations. These are the results of the study, so that there were only 14 patients transplanted in the last 2.5 years, and the mean age of these patients was also, they were all adults, the mean age was 29, and there was also 4 patients with a major blood group incompatibility, and most of these patients had severe sickle cell disease with all kinds of complications in the past. And one of the inclusion criteria was organ damage due to sickle cell disease. And if you look at the response, of course, the hematological response is beautiful. Patients have a normalized laboratory with normal hemoglobin levels, normal reticulocytes, and normal LDH. And if you look at the outcome, there was one mortality. That was a patient who had graft failure and died of severe infections and EBV reactivations, which was really dreadful. But if you look at the overall survival and disease-free survival numbers of this study, of course, it's a much smaller study than presented just a minute ago, showing that more than 90% of the patients had an overall survival of all these adult patients. This disease-free survival was similar. There was graft versus host, acute graft versus host only in one patient, and there was minimal graft versus host, chronic graft versus host in other patients, and showing reactivation only in the patient that had graft failure. If you compare the T cell chimerism, you see also a difference. So the stable chimerism was leveled at 70% as compared to 50%. So there is a stronger T cell chimerism for the patients that have been preconditioned in this study, which may have effect on the graft failure and also on the viral infections that were very limited. The last but not least point that I would like to raise is the haplo-identical bone marrow transplant, because the presentation I just gave on match-related donor transplant in adult patients can only be applied in, let's say, between 10 and 50% of the patients, because they have a donor. But the majority of patients with sickle cell disease don't have a donor. But almost 80 to 90% of those patients have an haplo-identical donor. It can either be their children or their parents, or a brother or a sister that is not completely matched. And this is currently done in a Vanderbilt global haplo-identical transplant learning collaborative with different centers all over the world, who are trying to find out what the best scheme is for children and adults to transplant them by haplo-identical transplantation. And I have the opportunity to show you some of the results of this collaborative. You see here a inclusion of 56 patients, and the engraftment in this study is impressive. In the adults, 100% engraftment. In the children, it is less, with a duration of the neutrophils in 20 days, and in 32 days the thrombocytes are above 50, and there was VOD in only one patient. Also interestingly, graft versus host rate was low, only 7%, and chronic graft versus host was in only 2 patients of 56 included so far. The graft failure was only seen in the children, and the protocol will be changed for that group. But I think it's important to say that even haplo-identical bone marrow transplantation in sickle cell disease in adult sickle cell patients can be applied, and will have a 100% disease-free survival, although there is a mortality of 5%. So 5 out of 56 patients died during this study because of the transplantation. So in summary, I would like to stress that although allogenic stem cell transplantation is there for years, for adult population, this is really a curative option. And despite all the new drugs that have been discussed so far at this presentation, and also a previous presentation during ASH and ASCAT, I think that this is something that we should not forget, and should try to find the patients that have an HLA identical sibling, and even then, if they don't have that, haplo identical transplantation is a very good option for those patients with a high overall survival and a disease-free survival for those patients. This is the last slide of my presentation, but no, it's not my last slide of the presentation, because I would like to come back to this figure. So I started off with this scheme of all the different targets you can choose to treat patients with sickle cell disease. And if you look at the pyruvate kinase activation and look at which targets this has an effect, it is almost all targets except for cellular adhesion and vaso-occlusion we don't know. If we look at the NRF2, which has an effect on oxidative stress, but also on hemolysis, on polymerization, it actually has an effect on almost all targets which are involved in the disease. And of course, looking at the last option I just talked about, if you cure the disease, well, of course, all the problems will go away. So, well, these are, I think, the most emerging therapies at different levels. So allogenic stem cell transplantation is already there, and we have to recognize this as a therapeutic option in adults. The other drug, pyruvate kinase activation, we will hear from that a lot, I guess, the coming years, with the 2 phase 2, phase 3 studies coming up. And NRF2 activation, well, we have to wait for that, but that looks also promising. And I would like to thank you for your attention. I'm happy to take questions, of course.
Thank you so much, Bart. I have to tell you, I was really looking forward to your talk, and you did not disappoint at all. You have quite a masterful way of making complex material understandable, and I'm sure the audience feels the same. So, and I'm definitely taking notes here about what sort of the new sort of pathways and thinking about old treatments such as allogeneic transplant and putting them back to the forefront of our mind. So thank you for doing that. I know my colleague Miguel Abboud has a question for you. Miguel?
Oh, you're muted, Miguel.
This is coming back to the question that was asked before. You know, Biree did a great job, and Julie Kanter presenting the approved new therapies. You talked about upcoming new therapies, pyruvate kinase and all of these things. How is this going to fit in the schema with bone marrow transplant, which I do all the time? In fact, we just finished today our JC accreditation, but it is a toxic and relatively aggressive procedure for most people, especially in the allo setting. How are you going to fit these new therapies with bone marrow transplantation?
Well, that's a difficult question. I would say for patients who have a HLA a match-related donor, so have a brother or sister which is matching them completely, there is actually that's the way to go in every patient who have a severe form of sickle cell disease. And the reason is that it has hardly any toxic effect. It has no effect on fertility. That's different from the regimes you have to use in children. So it is such a mild conditioning regime that is a outcome that is a treatment you should offer to all patients, irrespective of what kind of other drugs they are on. With respect to the allogenic stem cell transplant, that is something different, because that is, of course, a more toxic therapy. Patients have to be in hospital for more than 30 days. They have mucositis. That takes a while before they are up and running again. So at this moment, we use this for patients who have still complaints, still multiple crises, ongoing organ damage, despite optimum therapy that we give them now. So if you have a patient who's not responding that well on the treatments that we just discussed during this meeting, well, those are the patients you can offer a haplo-identical bone marrow transplant. If you inform them about the risk, of course, there is still a risk of 5% that you die on such a procedure. And of course, you have to be able to be in a hospital for such a long time. So some patients, especially people with very young kids, they don't like to go into the hospital and take this risk. But this is something you have to discuss with the patient and try to find out what their options are and what they are willing to risk and to do. But it's to look at allogenic stem cell transplantation as something that is a lottery if you die or not die. I would like to stress out that this form of transplantation that is done now, which is low intensity, is really a therapeutic option, and that cures you for life, and that's not the case with all the other drugs, of course.
Yeah, I have a question for you. Actually, there's one from the audience that trumps my question. It says, since reduced intensity conditioning, I gather, cannot ensure complete chimerism, the question is, this person is wondering, what is the minimal level of donor engraftment necessary for disease-free survival in sickle cell disease post-transplant?
Yeah, that is an interesting question. So I demonstrated the myeloid and the T-cell chimerism. And of course, if you look at the sickle cell blood, if you have a myeloid, chimerism of above 80 or 90%, as it was in both studies, then you will find no more sickle cell blood in the patient anymore. So the patients who had a donor without sickle cell disease, the HBS level was 0. In the patients who had a carrier as a donor, you will find exactly the same HBS level in the blood as it was in the donor. That's completely identical. The chimerism is more important with respect to the T cell, because the T cell chimerism, that is a risk of graft failure. If that goes down below 30, below 20, then graft failure is coming up, and then you need to intervene with drugs, either with Andemariam or something else, to try to get them into a good chimerism. But so to answer the question, I think that the chimerism for the myeloid cells is actually high enough, even with this reduced intensity conditioning. The crux is in the T cell, because that will have an effect on the graft failure.
Thank you. So my question is a little bit more philosophical, ethical. I'm really interested in your thoughts on this, Bart. So thinking about where the majority of the world's burden of sickle cell disease is, right? Yes. So places with minimal access to bone marrow transplant, possibly minimal access to clinical trials and novel therapies, but maybe not. Does that inform your thoughts on how we should be focusing our attention on novel therapies? You get the question?
Yeah, I get your question. Of course, it's a very, very valid question, because bone marrow transplantation cannot be applied in the whole world, and especially not in the part of the world where sickle cell disease is so prevalent. perhaps we will find a way to make it more easy. And I will give you an example. In the conditioning regime, which I didn't discuss completely, there is a very expensive drug involved. It's called tiotepa, which is not available in Brazil. But also Brazilian centers do cooperate in the haplo-identical transplantation study. And they have used a different approach with given somewhat more radiotherapy and have identical results. So you can find a way to make it more, make it less expensive and to get it done in countries where they don't have the resources they have in other parts of the world, especially in Europe or in the United States. But you are right. You also need other drugs, and that need to be available for those patients. But don't forget what the price of Voxelotor and Crizanlizumab is on a yearly basis. So those drugs are expensive as well.
Okay. Well, there are no more questions, and all good things must come to an end. This was a wonderful session. I know I learned a lot, and we will have now a 15-minute break before we come to our panel discussion, where we are going to continue addressing some of these burning issues about the application of new therapies in real life, what are the issues, and how this benefits users. Thank you very much. I would like to thank my co-chair and speaker and Bart and Julie Kanter for a wonderful session.